So as Tom said, I'm faculty in the Department of Social and Behavioral Sciences in the College of Public Health, and I direct the Risk Communication Laboratory, which is my research laboratory, where I specialize in risk communication. And, Whitney and I are happy to be here with you today. We've talked a lot about vaccine hesitancy between the two of us and have done some work. So our plan today is talk a little bit about risk perception and structural barriers and how those are associated with certain groups, and then how that can be used to kind of think about how to talk to patients within the clinical encounter. So this is what we'll be going over today. I'll be covering the first two, so talking about risk perception and its relationship to behavior, discussing what specifically vaccine hesitancy is, and then Whitney's going to be talking kind of about really giving a deep dive into contextual factors that are related to vaccine hesitancy in certain populations, including some of what she's heard from Temple Hospital employees with some of the focus groups that she's done. And then we'll end up kind of talking about communication strategies and resources that you can use. And we're really hoping then to leave the last part of this to kind of open it to discussion to you all to think about how that applies in the clinical setting. So let's get started. So first, I'd like to talk a little bit about risk perception. In general, people are pretty resistant to risk. So there are those kind of crazy people who want to jump off airplanes or out of airplanes. Most of us do resist risk. And the weird thing is that despite the resistance to risk, we also don't believe that we're at risk for things. So we don't think that, we'll have a heart attack even if we're a smoker, or we always think we're a better driver than other people. Why is this? So based on information that's available to us, often the reasoning process induces us to think that some type of hazard in question is not really a real risk. And this is especially true for the more we know about the hazard, because we feel we have some control over it. And that's that optimism bias idea. So it's basically the idea that it's not going to happen to me. When we do this, then, when we minimize these risks, this is called attenuation. So the attenuation may lead to, could be potentially serious adverse consequences by either underestimation or an under response, which means that we actually may take certain risks because we've decided that some negative consequence won't happen. It's kind of sort of a crazy way that we deal with things. If we didn't attenuate at least some risk, we'd probably never leave our houses because we'd be afraid of everything. So then, the interesting thing is that, when we underestimate risk because we believe ourselves to be safe or invulnerable, it also means that we often don't behave in ways that are going to protect us. So when we feel safe, we don't feel obligated to do anything, which sometimes leads to this divide between what experts, clinicians think and what the lay public thinks as what is actually risky to them. And we'll talk more about that in the context of COVID as we go here. So let's talk a little bit about kind of what happens when we do feel threatened, like we do in a crisis like COVID-19, and some of the factors that might increase or decrease our feelings of risk. We estimate risk, especially in a crisis like a public health crisis or other types of things, based on a list of things. We do this unconsciously. It's not like we sit and list them out for ourselves, but there are some things that actually make us underestimate that risk or attenuate it, and some things that make us overestimate the risk. I'm not going to obviously talk about all of these things, but I do want to highlight a couple that I think are most important in the context of COVID, and then specifically vaccine hesitancy. So the first two are control and choice. So if we think about driving, Most people feel safe when we're the driver rather than when we ride as the passenger, mostly because we have control over the car. And so we don't think there's as much risk because we have that control. The risk that we choose to take seems less hazardous to us than one that's imposed to us. So, just think of your own behavior and think about whether that's true. For most of us, it is. Similarly, if we have the choice to do something like texting and driving, we feel we have control over the situation. Our optimism bias is present, and we don't really think that anything bad is going to happen, even though we know it's a risk. It's that always that, well, I'm better at it than someone else. So control over and choice kind of over the process that determines a risk probably isn't going to appear so great as when the control and choice are not there. So if we think about it in the case of COVID-19, we have choice and control over where we go and what we do. And if we do, we are probably feel less risk than maybe what is the actual risk is for us. If we think about it in the beginning of the pandemic, especially on the coast, the east and in the west, we were not given a lot of control or choice, if we remember back then. So places were closed, we were told to stay home, there were curfews in many areas. These actions kind of take away that control, and actually then risk becomes heightened during that time. But as things eased, or and more control and choice are provided, that risk starts to lessen. And that's what we started to see with people going to people's houses for Christmas and Thanksgiving, and all of those kinds of events. And when that perceived risk goes down, it makes us less likely to do the things that we should do to protect ourselves. I think it's also important to understand that in the context of parts of the country that did not have a lot of imposed bans on things. So they didn't take as much control away. And so in those parts of the country, there's a lot more attenuation of that risk from the beginning. I think the same can then be applied to vaccination, which we'll talk about in a second. The next is just whether the risk is new, and we have a high awareness of it. So, new risks tend to be more alarming than those we have experiences with. So certainly at the beginning of COVID-19, it was new and scary. Our risk is heightened. But the more time goes on, the more we perceive it, we understand it, the less concerned we get. So if we think about it, in terms of something that might be very common versus something that's very rare, like breast cancer versus a very rare cancer, the awareness is often driven by how much information we have. And if we think about it in context of COVID, so much is driven by the media and other informal sources of information through social media, that we tend to get sick of it. So, the more we hear about it, the less exotic it becomes, and the harder it is to maintain that risk. Next is possibility of personal impact. So, any risk would seem greater to us if we or others close to us are the victims. That's why often, this concept of statistical probability is irrelevant in the public's view. And why in certain geographic areas that may have been hit hardest, the sense of risk may be higher. But now you're starting to see kind of the risk in other parts of the United States, so it's kind of been in one part is higher and the one part it's lower, and then it kind of changes over time with the epidemic. But it's hard to sustain that kind of for a long period of time. And I think as some people start to get vaccinated, we're actually going to cause a further lull in this kind of feeling of threat, because people say, well, we are vaccinated now, we don't have to worry about it. Trust and fairness, very important, I think, especially in the context of COVID-19. The more confidence we have in those responsible for our protection, the less we feel concerned. The less we trust them, the greater our concern. And this may be different, obviously, for different groups of people. with COVID, much of it has been politicized, and the messages have been, very mixed from the very beginning. So this affects kind of feelings of trust and fairness in the process. It may also cause some to have a heightened risk and some to have a lower risk, which is why you see such differences in behavior across the country. Um, Also, people you have to face greater risks than others and aren't benefited in some way may look at risk a little differently, which is pretty critical with vaccine hesitancy, which I'll talk about here in a second. And then finally, I think process is a really important one. Um, Similar to trust and fairness, but here you're looking at kind of the agencies or government, from the feds down to the local, that have to demonstrate that trustworthiness and honesty and concern about the impacts of the risk. Um, if not, that risk perception becomes very negative, and the trust is much less. So, things like having mixed messages about data, about testing, school reopenings, shortages of COVID vaccine, who is able to get vaccinated or not, are all things that impact trust. And if we just think about what happened here in Philadelphia recently with Philly fighting COVID and that kind of whole debacle, it's hard to see how that helped those who are vaccine hesitant to do anything but be more hesitant because of the lack of trust issue. So I think it's important to note that there's a time at which not trusting the process actually gets people to the point where they just give up and not really care what happens, or in the case of vaccination, just don't get it. Um, so now I want to pivot to kind of talk specifically about kind of how all these things have affected our response to COVID-19, and then specifically to vaccine hesitancy. So I'm sure we all remember the start of March last year. It's hard to believe it's been almost a year. That as things kind of moved forward through May and the summer, much of the country was locked down. We saw lots of images like what I'm showing here on the screen. Healthcare workers such as yourself, people in masks, mass graves, outside places to keep bodies, all of these things were there, and they're still there a year into the pandemic. We also have lots of messages and communications about how to protect ourselves. It was, and it still is, I mean, everywhere. We can't really get away from it. We also have a ton of media coverage, so kind of every day, 24/7, lots of people talking and lots of people saying very different things. And the problem, I think, with all of this coverage is that people have very short attention spans in a crisis, have a hard time processing a lot of this information, especially when it deals with medical issues. And that kind of health literacy issue becomes very important for a lot of people. There are also just so many mixed messages because we tend not to talk in absolutes in science. And we have so much communication happening from so many multiple sources, much of which is contradictory. And it's hard for, people to keep up with that. It's hard for me to keep up with that. And I do this for a living. On top of that, just tick tock, right? Time goes on and we want to get back to normal, to that state of optimism bias that we want. We don't want to think that we're at risk for negative things to happen to us. And, as we moved into the summer of 2020 and then into the new year this year, we've started to see a lot more pushback about complying with directives. And we're seeing this now bleed into vaccination and some of the messaging that's coming out around vaccination. So again, people can kind of only have a heightened sense of risk for so long. The longer it goes, even as we're racking up the case deaths, we just hit 500,000 deaths, which is a little crazy to think about. the harder it is to kind of stay in that heightened sense of risk. And the more we start to say to ourselves, well, it's okay if I go to my grandmother's house for Christmas or I go to a bar when I'm on vacation because those are normal activities and people want to feel normal. So it really is kind of this cascade that's happening that's affecting people's behavior. And now we're starting to see this within vaccine hesitancy. So we know that we know that in public health that to be effective, a certain level of vaccination, herd immunity, has to occur to create enough to protect the public. And in the case of the COVID vaccine, estimates are that we would need to reach probably at least 75 to 80% of the population to create that immunity. Um, but that would be stymied if enough of the population obviously is hesitant to take the vaccine. So in general, vaccine hesitancy is categorized kind of as a continuum, which is shown here. Um, from those who accept all vaccines to those who accept but maybe delay or refuse some vaccines, all the way down to the end, which is those that refuse all vaccines or deny that vaccines have any benefit. The World Health Organization has a Euro vaccine communications working group, and they propose this kind of 3 C's model to explain vaccine hesitancy. The first is the confidence, which is just defined as kind of trust in the effectiveness and safety of vaccines. Complacency, where the perceived risks of vaccine preventable diseases are low, and then just convenience. So how, what's the physical availability and ease at which vaccination can happen. In the case of COVID, I think the majority of the hesitations coming from the first bucket, which is that confidence in its effectiveness. But I think as we've seen, especially here in Philadelphia, the convenience piece, just the ability and ease at which that vaccination can happen is probably having an effect as well. I think there are a couple things that are being driven by that. One of which is the speed at which the vaccinations had been developed. Um, not trusting that process, and kind of the lack of trust then in those who are in charge of the effort, both from the federal government down to kind of pharmaceutical company to healthcare institutions who are providing it. I think it's also been exacerbated by the vaccine shortage, and the kind of disorganized rollout, with the perception that those most at risk are not getting equal access to it. So again, the trust and process are very key variables in kind of how people behave. And most surveys suggest that about 30 to 35% of the population falls into the category of being what we would call hesitant. So that would be where the people are saying they probably or definitely will not get the vaccine. If all those people don't get vaccinated, then we would fall below where we would need to be to produce a viable herd immunity. I think there is some good news, which is that vaccine hesitancy is going down. So as you can see here, the number who say they definitely or probably would be vaccinated has risen from about 63% to over 70% between August and December of 2020. I haven't seen a new one that's come out just in the last 2 months, but my guess is it's probably a little bit higher as well. Um, One way to kind of think about vaccine hesitancy is through the lens of theory, and this is specifically diffusion of innovation theory. So I apologize, I'm a professor, so at some point theory has to be brought up. But the theory explains kind of how the public adopts new things, and it's been used in a variety of fields. It can be applied quite well in public health, and it really postulates that the rate of adoption of something new, like getting vaccinated for COVID, is usually first dictated by what the attributes of that innovation are. So for instance, is it better than what it's replacing? If you can see others doing it, is it compatible with the audience's values or past experiences? And the more of these that are positive, the faster the innovation is adopted. Another piece of the theory that I think is really important here is that the public can also be kind of separated into these 5 groups. And then if you can get these, what we call the early adopters, which is about 13.5% of the population, these folks are kind of leaders who are looked up to in communities. And if you can get them to adopt something, you're much more likely to be able to get the early and late majority to adopt as well. But this means, you have to get those community leaders quickly vaccinated. And if you do, then a significant chunk of the rest of the community, those early and late majority, will come on board, which means you actually don't need to focus too much on the laggards because they're very hard to get to change in their behavior. The problem is that our vaccine strategy in the US so far, with only having certain groups vaccinated at a time, actually hinders this process, because it means what you're doing is that it's very hard to get kind of a large group of early adopters vaccinated because they're being parsed out in so many different vaccination groups. Who are the most hesitant groups? Most of the cross-sectional survey samples we have seen focus on hesitators seem to be Black and brown people, especially Black African Americans, women, and those who are younger. So those kind of overall demographic groups tend to be the most hesitant. In addition, having lower education and income levels, and not having received a flu vaccination in the last year are predictive. In a study that I did, which was in New York City, Miami, and San Francisco, there was also interesting correlation that we found between those who didn't pay attention to COVID related news, and also in people who had a dissatisfaction with their own health and their access to healthcare. Those we found were actually quite predictive of vaccine hesitancy as well. If we think about, why Black African Americans specifically are more likely to be hesitant, all we have to look to is kind of that risk perception and history. And Whitney's going to go into more detail on that. I think another interesting thing there, if you look at some of the survey responses by Black African Americans, so this was a Kaiser Family Foundation one that was done. What they found was that, they had about 20 percentage points lower on compared to Hispanic or white adults on if they said they would be getting that vaccine. And these differences are actually independent of political leanings and actual risk factors for infection, such as having any kind of secondary health conditions or living with an essential worker. Another interesting note I think here is this was some recent research from the Brookings Institute seems to suggest that Latinx populations are also certainly not the same in their vaccine hesitancy. So if you look at overall studies, they showed that about 28% of Latinx said they would be unwilling to get vaccinated, which is very similar to Caucasian white adults. But if you look specifically at countries of origin, people who are of Puerto Rican and Mexican descent were actually much more likely to be hesitant. So people of Puerto Rican descent were 7% higher, saying they would not be vaccinated. And these two groups are the largest national origin groups among Latinx in the US, certainly also here in Philadelphia. And if you look at the reasons that they say that, you also see, very similar issues, but the group has also expressed concerns kind of about the treatment of immigrants in the US in general, and distrust specifically to the Trump administration as reasons for not wanting to get vaccinated. And that has kind of bled over into now the Biden administration. So, Whitney.
Oh, right. Thank you so much for a great start. So like Sarah mentioned, I'm on faculty in the Department of Emergency Medicine, and I'm also a new faculty member in the Center for Urban Bioethics. My task here today is to try to delve a little bit more deeply into the mindset and context of hesitancy, with a little bit of specificity to the populations of patients that we tend to see in and around North Philadelphia. So I'm thinking and do my work with African American, Latinx populations, people who experience poverty, and people who have been exposed to trauma. I want to try to help highlight points of maximal relevance to our roles as clinicians, insofar as that the context helps us to understand how to help our patients make better decisions about whether to get the vaccine or not. We've been doing focus groups and informal chats with neighborhood residents about perceptions of the vaccine, and wherever possible, I'll quote directly from the community members in this part of the talk. So I'm just going to take a centering breath here and acknowledge that to the extent our work as messengers has like this really direct impact about, I think, how our own lives are going to change, how things are going to change nationally. Like, you know, this has real downstream meaning. And I think that makes this whole idea, at least for me, a little bit anxiety provoking. And I can't imagine for you all who are in primary care how that must feel. And that's really understandable. But I also want to right size our expectations of ourselves and our community of patients, both because I think it's necessary for us to do our work effectively, and also too much aggression, and I'm going to get into this in just a second, I think actually is counteracting, or potentially can counteract the goodwill that we're really intending when we want to strongly encourage people to vaccinate. Next slide. This is really hard and complex work, and it sits, in my opinion, in the nexus between biology, psychology, sociology, and history. And then the person is contextually, you know, their individual needs, their family needs, their community needs and ties, and also their relationship to society. And all of those things are at play, in addition to all of the individual conversations and risk attenuation and the things that Dr. Bass was talking about. So on top of that, we know we have malfeasance, misinformation, disinformation, nihilism, and some of those again are kind of like historically situated. And these are issues that have been really baked into our country and in a lot of communities of color for centuries. And we've made a very little progress dismantling them, as evidenced by our low seasonal influenza vaccination rates. So I say all that to say that as a bioethicist and a researcher who focuses on these communities, I'm really thrilled about all of the information that is coming out about these foundational breaches of trust between minority communities and physicians. It's nice to see all of that stuff get a lot more traction, but it makes me worried about two things. First, I want to caution that it would be, in my opinion, inappropriate that we equate equity in our vaccination strategy with like the velocity of the vaccination program. The number of people that we vaccinate and the time over which we do it is important, but I think in minority communities, it's a really crude marker of success. And I think it could potentially lead to us collectively thinking that we need to push people towards vaccination and push people who are more in that kind of back end of the bell curve that Dr. Bass was showing towards the front of the line. We absolutely have to prioritize concerns of equity for people who are expressing interest, who are kind of in that early adopter and ready to go phase. But once we get past that area, then we're going to transition, from issues of barriers to access and really more into this issue of hesitation to accept. And pushing can sometimes feel like forcing, which can actually further entrench their position. So we need to be prepared to, see a flattening of the slope of the curve of how many people we're vaccinating, and neither see that as a signal to push people harder, and also not to turn that into, well, nobody else wants to get vaccinated and I'm going to give up trying. My second concern is that the information doesn't feel to me that it's necessarily being presented in ways that are digestible for us as clinicians, right? It's really critical that we understand these historical contexts, but I think it's really hard to map precisely the impact of history on the present cultural moment, and then certainly even more difficult to translate that into individual perceptions on vaccination in a way that was like useful to you on a day-to-day basis as you're encountering patients. And then it's also really hard to translate effectively the aggregate knowledge that we have about bias and hesitancy and things like that into culturally relevant communication strategies that don't veer into stereotype, right? So you have to be able to understand the context in which certain communities have lived their lives and have experienced the medical system, but you can't then use that to say, well, now I understand everything about what people are going through. And like, I'm just gonna, use certain phrases and heuristics to like make assumptions, because that's stereotyping and bias. And that's the opposite direction than what we wanna go. That would be pretty unacceptable. So, even though I think logically we understand there's no real straightforward answers to these questions, and no one size fits all flow chart, to get someone from that kind of hesitant space to the early adopter space. But again, I think the weight of the moment can sometimes lead us to ask a little bit too much of our current understanding of what's going on. And so what I'm going to suggest that we do is that rather to try to get the right answer, that our most realistic strategy is to try to gain a greater understanding of our patients in a context that expands and refines the tools that we have for effective communication and shared decision making. So stated differently, there's no such thing as a disembodied rational actor. There are no ideal scenarios. In the real world, it's messy, and it's really especially messy for a lot of the patients that live here in North Philly. And then when patients are making their vaccine decisions that maybe seem counterproductive to their health, it might seem a little less baffling and frustrating to you on the front line if we can appreciate that person as kind of being like this physical and emotional manifestation of all that they've seen and experienced, all that they've gained and lost. And then also they have the shared history of experience, gain and loss of their community, of their family, et cetera. So I'd like to ask you to consider that what drives a lot of people's decision-making that's not health promoting in this community is often a direct result of trauma or maladaptive responses to trauma. Next slide. When we understand ACEs and trauma theory, we know that people exposed to high levels of trauma may process and perceive their risk differently, even outside of those contexts that Dr. Bass just like so clearly outlined. There's a further maybe sometimes disconnection, sometimes disassociation, but there's a variety of responses that result from the disrupted neurodevelopment that results from the other, kind of foundational building blocks to a person who's experienced trauma. And when you, oh, sorry, I'm not quite done with that slide. I think that, when you think about like the risk calculation for a young African-American man here in North Philly, it's going to be different because of his awareness of his constant threat of gun violence. A person who might be struggling with opioid use disorder in Kensington may have a different perception of their value and worth in a way that makes the basic outlines of risk and the way that we message about, keeping yourself healthy, it may not make sense in the context of how they're viewing themselves at this moment. So again, context really matters. And if we look at that foundation of that pyramid, we can see that our North Philadelphia patient population is influenced by all the drivers of upstream traumatic impact, right? Downstream. Keeping in mind that exposure is not destiny, that we never want to stereotype, and that the schematic doesn't draw any attention to strengths, to resiliency, to other protective factors that are definitely present in this community because this is a community of survivors. But if you're Black, Brown, or intergenerationally poor, you have definitely experienced the generational embodiments of trauma that are the base of the ACEs pyramid. And if you currently live in North Philadelphia, you experience the impacts of divestment and structural oppression, which is the second block. And we know from the ACEs study that was done in 2016 that at least 70% of Philadelphia writ large, and then higher levels in communities that are predominantly communities of color, have experienced at least one ACE in their lifetime. So it probably makes sense to approach all of our patients with a communication strategy that accounts for the possibility of this disrupted neurodevelopment, and then the social, emotional, and cognitive impairments that could result from that, and then the maladaptive health risk behaviors that may result from that when we're talking about vaccinations. Okay, so I want to use that framework to then kind of highlight some of the things that I think contextualize some of the fears around vaccination. So I hope that you can see. So when we're thinking about this generational embodiment and historical trauma, someone in one of our focus groups said, so like I grew up, you went to your visit and you got all your shots and you just weren't able to talk about any side effects. Like my parents are from the South, so any reaction that you had, it was almost as if you were being ungrateful, because when they grew up under Jim Crow, they didn't even have access to doctors half the time. And that continued for them, like a lack of access to healthcare for one reason or another, right up until my brother was born, who was born in '65, had to be born in a car because he was too far. they were too far away from a community hospital that would have let Black people in, or an interracial couple in. So then the next one, well, it may be in my family because my family comes from South Carolina and North Carolina, and my aunties, they use a lot of herbs. If we got sick, we make up a poultice or some kind of herb mixture, whereas we thought we'd feel better. So it wasn't a thing where I thought I needed the flu shot. I don't believe anyone in my family has had a flu shot. And maybe it's generational from where we originated using herbs and stuff, because I know my family trusted herbs more so than they trusted doctors, medical professionals. So I don't have it's just that I just came up with whereas though this is what we do. So I'm going to stop here to kind of highlight that this is kind of two sides to the same access coin, and an access issue that's resulting from structural racism. So both of these are middle-aged women who have family origins in the South. And although one person is, willing to vaccinate or had at least a family narrative where vaccination was something that we were going to get because it's one of the only things that were being offered, this idea that this lack of access to care also can result in this, the exact flip side, right? That not that I'm more interested in it because it's been denied to me, but now I don't really even have any context for the idea that this is something that I should do. Preventative medicine doesn't involve allopathic medicine. It only involves, complementary and alternative therapies. Next one. So, we've had multiple people in our work just ask the explicit question, is this an experiment? Are they experimenting on us? And I would hope that it's not news that this is coming from a very real place. The Tuskegee study is constantly referenced. If you want to get more in depth into a number of other egregious medical issues that and ethical lapses and like just frank, on experimentation, surgeries without anesthesia, digging people up from graves in order to use them for experiments. Medical Apartheid by Harriet Washington is an excellent read. It's interesting that you brought up the stratification of Latinx community, because this Stop Forced Sterilization poster, I included that specifically to think about the narratives of Puerto Rican women who were put into contraceptive trials early on with or without their permission, and weren't allowed to stop the medications even though they were complaining of a lot of side effects. And then we also know that Guatemalan people in Guatemala were placed in a similar study to Tuskegee, which was actually even more egregious because they actually infected some of the people rather than just untreating people who were already known to have it, which is, to me, another level down. So the next bucket that we can talk about is kind of like, again, that kind of social conditions and local context, the neighborhood factors that influence people's behavior, and then I think their feelings about vaccination. So one of our participants said, so in the greater media, including our president, people are saying, oh, well, it's your fault if you get it. You know what I'm saying? Or because you didn't eat right, or you didn't do this, or you didn't do that, or you could have moved, you could have moved from the red line area. You know what I'm saying? You didn't have to, like places where they have astronomical asthma. So I say this to say, I'm not saying that people don't have to take responsibility, but what I'm saying is that there are reasons why we're more likely to suffer more than other people, other ethnic backgrounds. And I think knowing that should fuel people to get on social media and look up and Google stuff, because they say the average Black person reads 8 books a month. It's just not in book form, they're in social media. I just included that last part because I think it's a cool, a cool concept, and at least a different take on health literacy. And I'll get back to the kind of absence of us in social media, which is, I think, a pretty big threat to our success in this vaccination strategy rollout. So, this participant was hitting on something that I also hope is at least a little bit known to all of us, that Philadelphia and most other cities like it have had an intentional segregation practice, and not only to put certain groups of people in certain parts of the city, but also to specifically divest from those communities at the outset, right? So it's more difficult in the time of the Great Migration for you to get a home loan, for you to get a small business loan, for public works projects to be have uptake in the communities that were in red. And so now, 100 years later, we're dealing with the downstream impacts of that, which are on the left, the purple one, the pattern of incarceration and reinstitutionalization, which mirrors that exact same red line pattern. And then on the right, the number of Philadelphians who are living below the federal poverty line. The other big one I think, we have to think about, especially in this neighborhood, is violence. The extent to which I would hope the events of January 6th highlighted that there are some folks who are going to be perceived as criminals no matter what they do, and some folks where literally they have to get to the front door of the Capitol to even be perceived as a threat. The way that that influences how certain people in certain bodies may feel about their worth, it should not be underestimated in terms of then trying to suggest to that person, we value you enough to have you take this vaccine that we don't really know a ton about, right? So some of these ideas and the way that we think about the messages, we have to put them in the context of how we're also treating these people in every other part of their lives. And you can't, disentangle those, right? And it's not just like the national thing. I mean, we have a legacy here in Philadelphia, going back to the bottom right picture is the MOVE bombing from West Philly, right? So we know that type of kind of state sanctioned aggression is used in ways that, we don't necessarily participate in that system, but because we are also part of a large social sector that sometimes is described as helping, but can be hurtful, those narratives get kind of, interwoven and a little bit messy for people. So it's natural for them to have some hesitation in all spaces because they really don't know where and how they can trust. Next. And so, again, when you are living in a city where, you can live blocks away from someone who would possibly live 20 years longer than you, I think it's a little bit difficult for, not to understand that some people are probably going to think that their lives and their health count less than others. So here's another version. I want to do, this is one highlight that I thought was just an interesting and unique thing, but that's a positive and also something that I think we're missing in our modern approach to vaccination that may also be influencing how people kind of perceive vaccines overall. So this came up several times that back when we were in school, we would have to get vaccinated. They'd come to the school, we'd be in long lines, everybody in the classroom getting called down and you'd get your vaccination. So it's just, I'm not sure if it's based on the fact that inner city, and that's what inner city schools are doing back then or whatever have you, but that's how us as African Americans were able to get our vaccines a vast majority of the time. But I just came up in an era where it was better to get that vaccination than as to not get it. The person went on to say then that like they would be standing in line thinking, but are they experimenting on me? So there was kind of a both and to this story. But overall, this was kind of said in a way that was describing the fact that, vaccines happening in public, kind of like with full transparency, did give it a little bit more normalcy and perception of less risk. This one, I think, kind of moves us from the social context to this idea of like kind of individually, how does this move in terms of people's individual decisions? So this is one of our community health workers describing people that they are interacting with on the corner. One thing I'm going to do when I know that I got the flu and I can give it to others, well, I'm going to stay in the house until I get right, or at least stay out of the way of others. But nowadays, they just come right on out. And they go, like I said, they go to the store, get a tea, get some Halls, and they're cool. They're up on the corner. They're smoking cigarettes, passing it to their homie because they knowing that they got this flu. He's talking about COVID. See, this is what I'll be. So this is what's going on in the communities. You're coming amongst your friends. You're just passing it on because you're not washing your hands. You're not covering your mouth. You know what I mean? You're all going back and forth swapping smokes. This is what goes on. That's all I was saying. So I think, there's one way to interpret this, which is like, oh, this is a health literacy thing. But I think another thing to think about is this is a community of people who care for one another and whose social code prides the collaborative network that they have and their traditions and the ways that they behave over the, I guess, state or dominant narrative, which in most other contexts, the dominant narrative is oppressive to them. So it shouldn't, again, be super surprising that sometimes it's difficult for people to access just this part that we want them to, when we're not giving them access to everything else. And I think when you're broke, because I know what it is to be working poor, you just, as long as you feel better, you can go out and earn money for another day. And it becomes like a badge of honor that you don't miss work, that you support your family, you support yourself so you can get those sneakers or whatever. And what I see here in the clinic is that I've got to help a lot of people put themselves last. They say, oh, I don't need that, or oh, I'll be up right, or whatever, so they could give to someone else. And then when they break down, several families break down. So I just want to highlight that like all risk behaviors that are maladaptive are not necessarily like ones that we would consider, I guess, either dangerous or, come with like a stigma. Some of them have maybe what we would value as kind of like a nobility to it, or but also still stem from this idea that I'm either making trade-offs because I have to, because the conditions of my life don't afford me the ability to prioritize both my health and the health of others, and the safety of others, or that I have not had a precondition of safety, and so now I don't have an expectation to demand that for myself when it's available. So all that to say, I think that when you take these things into consideration, that you could also think about adding a trauma-informed approach to your thoughts about how you're going to message to people around vaccines. And Sam says it best when they describe the 6 major principles to that, which are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural and historical and gender issues. And I'll just take a couple minutes to kind of give you some ways to map onto those. So, safety comes in a lot of different formats. I think thinking about how, the clinic that you're working, is it creating a safe space for people in the waiting room where they're not, waiting for long periods of time and getting stressed out about what they have to do next, getting smiling faces in colleagues and people who are taking their blood pressure and all those kinds of things. Because if you want this person to have a mind space that's open to discussing vaccines, which may already be giving them a heightened sense of anxiety, and then they've got baseline issues maybe with some somatic feelings around trauma that they don't want to access, if they've already been kind of triggered in some way, then this conversation may not go as well as you want it to. So to the extent that you can try to be aware, even if someone's coming in and kind of hyped up, and to bring that down, if like the goal today is to really try to help this person who's got these other medical issues, has come in and said no 3 times, to kind of help them think about vaccine in a different way, creating safety is always going to be your first step. And we're trusted now. I think one of the other things that's coming out in these politicians, nobody wants to hear from them. The fact that we've been so selfless as a community, taking care of people, being on the front line, et cetera, our stock is going up. It's not perfect. I think we all know that. It probably doesn't feel that way sometimes because we're so burnt out in our day-to-day, but it does mean a lot. And I think not only just the vaccine messaging, but when you're getting into these conversations about naming and helping people understand that you understand as an ally what these contexts are, that is really validating, right? To have someone who is outside of your community and in a relative position of power say, I see what you see. I know I don't experience it. I don't share your narrative, but I understand why you're so concerned and why this worries you so much. That's very, very helpful to people, to help them feel more valued. But there's probably no more important person than someone who is a credible messenger who looks like them. If I think it's cool now, probably, like there's telehealth, right? So you're able to be in people's homes. So if you're seeing somebody's cousin who is always there and really seems like they get along with your patient, and this patient is having a hard time deciding what they want to do, maybe you can ask if this person can, loop in with you guys on your next telehealth visit to see if that person can bring more cachet, or even to help people identify someone in their family or their close circle that's already been vaccinated, because they may want to hear from that person more than they want to hear from you. And then also, I think for your patients who are vaccinating, give them that encouragement to then spread the word, because they can act as ambassadors in the way that Dr. Bass was talking about the early adopters. You can skip that one. So this is one of our community health workers. I will just read the top part, saying credible messengers would be us. If we get the right information, sorry, let me check myself. We get the right information, we're able to go out in our community and explain it. If I'm comfortable with it and I explain it to my community, some may take it, some may not, but they're informed. They know what it is. And I'm in touch with my community, the area that I live in. So the more information that I have, the more information I can provide to my residents in my community. Couldn't say it better myself. So, again, going back to this idea of making sure that what you're doing and how you're approaching this is in the space of understanding, but not in stereotype. I think, you could work on, your scripts, figuring out how you're going to plug into narratives that express hesitancy that comes from some of these historical contexts without making it sound, to me, I think it's hard if you're, not culturally congruent, then maybe that kind of feels awkward. So you might have to think about how you're going to, refine your message and try it on a couple different people that you could trust. But you do need to bring attention to the injustice. If people bring it up, if you ignore it, again, it kind of like reinforces, those feelings that this is something that only I'm seeing and that it's not valid. But I think also that, when you're dealing with someone who's actually giving you something that's like just straight disinformation or misinformation, there's usually a kernel of truth in that. Like there is a history and legacy of, malfeasance. Yes, I know about that too. But let me talk to you about what ways that I think that this might be a little bit different. So this is something that I use, but this actually came out of the mouth of one of our participants. So, but I think this is perfect. She says, I mean, they're saying that it came out with it too soon, like it's a new thing. Like there wasn't a template from other respiratory diseases, but people are not thinking. Like the whole world was working on this thing, and you'd be surprised what you can do when money is no object whatsoever. You know what I'm saying? And you have the backing, and people know they're going to be making money off this thing for years and years. That's why it's still 38 years and counting since they work for a vaccine, since they've been working on a vaccine for HIV. And this is a strategy that I use that's still thus far been effective. To, when people give me this, like it's going too fast, I just say, well, I think actually what we've learned is that all other vaccine processes have gone way too slowly. And we've got an equity problem with not pouring enough resources into the ones that matter. And so again, that kind of highlights what we know in minority communities as the truth about how power flows, funding flows, and that is, it's helpful for people. So I'll stop there.